is looking good. I know the title of my presentation is quite long, so I shortened it a bit for the slides to get at the main points that I wanted to highlight here in this presentation, which is use of intensive longitudinal measurement to understand sexual health and substance use in vulnerable populations. My title that I gave to CHIPS was also to identify intervention targets, and that is indeed what I'd like to also talk about during the presentation. So I think those of you who know me know I do, like a lot of us, a lot of different work in different areas. But I was hoping that this presentation could really hone in on the interest I have in intensive longitudinal measurement, and particularly in looking at this approach in vulnerable populations. Excuse me, my dog is no better than have a dog present during a talk. Sorry about that. So just very briefly, what I'd like to do is talk about why situations matter and why and how we study them, and then talk about a couple of different studies, well, really a few different studies that I've conducted over the years. And I'm not presenting data that's brand new, because I'm hoping to sort of build up to an argument that hopefully also informs maybe directions for work of colleagues on the call, but also that is absolutely informing the future direction of my work. So I also just wanted to really quickly provide just a quick overview of the terms. I know the ones on the left-hand side that are sexual behavior related don't need to be covered with this audience, but just to quickly say that I am looking at some of the same measures throughout these studies. Many of us are familiar with the CSD, but also the functional assessment of HIV infection, which has multiple subscales, which I'll look at or show in a moment. The K10, the Kessler depression measure, and then the PALMS. And while they are all not the same, I do sometimes employ the terms intensive longitudinal measurement, diary study, and at times ecological momentary assessment interchangeably. I don't really do EMA studies, but I know folks sort of lump those types of studies in with intensive longitudinal measurement and daily diary, as they rightfully should, because they are all very much highly related. So I often just like to start every talk I give with this graphic. I created this literally as a graduating or completing doctoral student at NYU when I was giving practice job talks, and it's stuck with me because this is really just the foundation of the kind of work I do. I have always been interested in understanding how context shapes processes, psychological processes primarily, and then other behavioral and physiological outcomes. So I focused on minority stress. I've looked at a lot of work. I've done a lot of work looking at religious institutions and other institutions, trauma and endemic conditions, many different process factors. And my focus has been on HIV, but I've also looked at substance use, adherence, and some of the work I also look at today is looking at psychological well-being. What I would hope to focus on, or would like to focus on in this talk, really are more the processes and outcomes, even though anyone who knows me knows that I'm very, very, very much interested in understanding how social and environmental contexts shape behaviors and outcomes. But for now, I'm going to just look at mood and emotion regulation primarily, and how they shape sexual health and substance use outcomes. Another thing I really like to do, I know many of us do this, is to sort of just lead off with my conclusions. And what I hope that you might take away from this talk after I'm finished is that sexual minorities experience fluctuations in mood, and that these fluctuations can predict risk outcomes independent of person level factors. And I will talk a little bit about the difference between within and between, or uh, time varying and sort of stable constructs later in the talk. But the idea here is that causal relationships between things like psychological distress and substance use, or drug use and substance use, do exist, notably when we look at non-clinical populations. So folks that aren't necessarily experiencing substance use disorder or have clinically diagnosed depression, but when we look at sort of a non-clinical population, we can see a very strong interrelationship between these within person fluctuations and different outcomes. Other thing that I'd like to really end on is thinking about communication and how important it is to not just healthy sex, but how important it is to understand the situational context in which communication occurs, and thinking about sex, as I think many of us do now, but as more than just an individual behavior, but one that involves partners. And I know many people in this Zoom room have done work in couples and have looked at sort of dyadic relationships, and I think that is work that is so important and necessary for us to really understand what's happening, and how best to think about interventions that can improve sexual health outcomes. And then just thinking about the importance of psychological well-being. And this day and age where we do have so many wonderful tools to prevent and treat HIV and other sexually transmitted infections, and tools to also treat and prevent substance use and substance use disorders. Sometimes we move right to the biomedical as the way to go, but I still think it's critically important for us to think about mental health, and particularly psychological well-being, as an important aspect of our intervention tools kit that we use in addressing HIV and substance use in vulnerable populations. So this is a graph from many years ago, one of the first studies I did independently, and it really shaped my interest in doing this kind of work. I was always interested in doing work that involved multiple assessments to sort of understand how, again, sort of situational contexts shape a given outcome. And so even thinking about things like depression, which has largely been measured in psychological and health research using the CESD, the Center for Epidemiological Studies depression measure, very well validated, used in a global context measure. But it's also a measure that primarily focuses on thinking about depression or mental health as a somewhat static person level measurement. So we measure someone's depression. We measure someone's depression level, and we sort of think we have a good understanding of whether they are depressed or not, whether we could group them in a category as a depressed person or not. And the reality of it is, like, that could be a moment in time and not necessarily an attribute of the individual, him or herself. And this graph sort of shows that. So this was a 2-month diary that we did, in which we did assessments every other week for depression. And the CSD measure was asking essentially, how have you felt in the past 14 days? So we were asking people to retrospect 14 days. Sorry. feel like I have a toddler behind me, and I sort of do, the dog. But as you can see, there are major fluctuations and changes that you can. I'm sorry, I'm going to have to just pause really quickly. Sorry. Sorry, I should have gone to my office. I clearly am not beyond Zoom. So excuse me, and I apologize for that. So if you look at this graph, you can see lots of variation occurring over the 2-month time period that we assessed individuals. And if you also take a look at these lines, this is where we traditionally think about the cutoffs for the CESD for clinical depression and severe depression. And while you can't track necessarily every line here, you can see that there are some individuals that cycle in and out of what would be considered clinical or severe depression. So even though we capture this when we measure depression using the CESD, we don't necessarily see the person across time. We see the person as a snapshot in time. This is the measure of emotional well-being, sort of similar to maybe the inverse of a depression measure like the CESD, but using the FAHI, the Functional Assessment of HIV Infection. You can see, again, lots of fluctuations here. And what really struck me was when we looked at social well-being, the subscale of the FAHI, looking at social well-being, and see, again, these same major changes across time. So this really spurred my interest in understanding not just why and how these fluctuations take place, but understanding situational context and the situations that might lead an individual to be of an increased well-being and those that would lead them to be in lesser well-being. So really quickly, just the background on this, and I think many people understand and know this body of research, where we have really considered, and again, this is not necessarily new, but the idea of just looking at the person level may not necessarily help us understand the full context of risk behavior, and that looking at distal and proximal factors is really important, especially the situational context, even though they're sort of frequently overlooked, largely because it's not easy to quantitatively measure on a large scale these contexts. But past theory and research has shown us, whether it's going back to Roger Barker's work from the 1940s into the 70s to more recently, Michael Ross, who talked about the risk situation, but thinking about these aspects of behavior, and that it's not that a person just exhibits a behavior continuously across time, but that these behaviors might be temporally, geographically, and socially bounded. One of the papers that has influenced me and that I still go back to was by Lynn Cooper, who wrote a piece in JPSP looking at persons and situations as they relate to sexual risk behavior. And one of the key things that she notes in this study is that traits are not necessarily going to predispose people to increased risk in a global or typical way. And so even when we look at, say, depression, or we look at substance use, that's not necessarily, when we look at it as a person level factor, going to predispose one to risk, but really thinking about the combination of a person and the situation that they're in to really think and to have a better and more comprehensive understanding of how risk situations may emerge. Why do the situations matter? Well, we think of people as going through life And for me, I think of people as going through life with different chapters. I mean, we all know that we grow, we evolve, we develop, but we also experience different aspects of life that pull and push on our well-being, on our mental health, our mood. Certainly, there are things that we all experience. The COVID pandemic is a great example of one of them, but then there are things that we uniquely experience, and some of those things, whether they be things like a pandemic or just an individual experience, they can hit harder for certain individuals or in certain situations. And that's part of what I'm interested in looking at and have looked at in my work in the past. Another model that I'll come back to, but that is another really important one for me, by Pamina Gorbek, many of us know, was just basically looking at how the combination of both individual characteristics and partners create a dynamic that actually shape risk and that shape HIV and STI transmission risk behaviors. And that's something, again, that hasn't necessarily been looked at in a highly in-depth level outside of our friends who have done a lot of couples research and dyadic research. And even there, I would say we haven't done a lot where we've done, say, these daily diary or weekly diary approaches to those types of studies, largely because it's very, very challenging to implement these types of projects. So when we talk about diaries, we are obviously talking about repeated measurements. A lot of folks who are not necessarily familiar with this line of work think about a diary and think about more of a qualitative data collection approach. And certainly diary studies have employed qualitative approaches. I will present a little bit of data where we've done that ourselves, but I'm thinking of them mostly as quantitative, structured assessments that occur on a repeated basis for a period of days or weeks. I have not necessarily done work that's focused on EMA, ecological momentary assessment, where you might have multiple assessments randomly during a day, but I have done daily, and even twice daily assessments, as well as weekly. And I find this data to be so rich because it does provide us prospective as opposed to retrospective data, and that prospective data is much less it's much less likely to be subject to recall bias and other forms of biases, though it certainly introduces its own set of biases like reactive effects and so forth, which I'm happy to talk about more when we do these types of approaches. But getting these intensive assessments over time gives us both data at the person level, which we're sort of used to looking at, and then also at the episode level or day level. I'm going to report on some findings from episode date or at the episode level where we looked at sexual episodes nested within individuals, but certainly just thinking of days, assessment days, asking people if they use substances, asking people how they feel. So you get a good idea of what's happening across time, but also on specific days. And after doing lots of studies employing these methods, we found a lot of different tricks to increase responsivity and to allow ourselves to get comprehensive data. And that includes, of course, reminders, but things like tiered incentives. We've employed loss aversion tactics, lotteries, and even or often use things like dummy measures to avoid skipping items. And the main thing is to try to make it something that's fun and not considered burdensome when you're asking someone to do an assessment for such a long period of time. So let me just get into data that we have collected now using some of these approaches, since I've spent so much time talking about why it's important. But just to give you a little bit of an example of what kinds of things that we can see when we look at these, when we employ these approaches. This was a pilot that we did that was just well, a pilot to inform a larger study. But all we did is for 14 days asked folks to let us know if they had sex, and we also tracked their anxiety levels using the profile of mood states. And you have 3 participants, there's 3 profiles here, and you can see that these are very different in some ways, in the sense that P1, almost the anxiety and sex track each other, whereas if there's an uptick in anxiety, there seems to be potentially more sexual behavior that occurs. P2 is the opposite of that, where if there's an uptick in anxiety, there might be less behavior that occurs. And P3 is sort of, there is almost no relationship that you see there. It's just anxiety is stable, sex is pretty stable over time. And those are the kinds of things that I like to model and see what sort of shapes these types of patterns. So I want to talk to you about 2 studies. Again, these aren't the most recently conducted, but I believe they still give us direction. And at least for me, they've provided direction for the kind of work that I intend to do and am doing currently. So the first study was called Project Log On, and a second study called Brothers Connect study. These were both studies that involved weekly diaries where we asked people to document their substance use and sexual behaviors over a 2-month period. Both had about 150 participants each. Project Log On was focused on men who have sex with men. These were largely, though, gay and bisexually identified men who were HIV positive. Brothers Connect was focused on younger Black and African American gay men who were both HIV positive and negative. And you can see a little bit of our sample characteristics for the Project Log On survey. These were all samples collected out of New York City. And historically, when I've gotten data from community samples, we have had a good number of participants, or a good proportion of participants, who are of lower socioeconomic status, often in circumstances that make them vulnerable to different both social and physiological outcomes. So you can see that a large number of the men in our sample for Project Log On were unemployed or on disability. There were only a handful, well, a quarter, that had a college degree. So a very sort of lower SES sample here. Many of them reported substance use, and also a decent proportion of condomless anal intercourse. And I will get back to this idea of, condomless anal intercourse. What does that mean in 2023 in the age of PrEP, and with highly effective treatments to make transmission among or from an HIV-infected person to a negative person highly unlikely if the positive person is virally suppressed? What does it mean if we're looking at condomless anal intercourse as an outcome? And that's something I think that certainly is a question that we should consider as a field. But I think many of us who work in the communities that are still most predominantly impacted by HIV, like Black gay men, Black trans women, lower SES individuals, know that PrEP and so the U equals U doesn't always apply as easily to these populations which don't have quite as great access. Also now and I am sort of talking about these 2 studies at once, I realize, but they are somewhat similar, so hopefully that's not going to be confusing here. But these are characteristics for the Brothers Connect study. Very similar in many ways to the Project Logon study. Again, these were both HIV negative and positive individuals, but we did have, again, a high number of lower SES men. Sorry. And just briefly, I won't spend much time here, but we have similar measures across these two studies. And when we look at their reliability and validity, these were both shown to be quite valid or quite reliable when both looking at the sort of between person or person level, as well as the within person or change aspect. So when we looked at predictors of condomless anal intercourse, or UAI, as was reported in this paper, one of the things that we saw was meeting a partner online, having a sense of sexual attraction, and talking about condom use, as well as where you met your partner, all had relationships to unprotected or condomless anal intercourse. And these were sort of in directions that you may expect, although one of the things that was always curious to us is that feelings about partners like strong sexual attraction, which you might think would lead to or be related to more risk behavior, actually seem to be related to less. And again, that's something I'd like to get back to because we've looked at this in other studies now. But we also looked at things like substances used before the sexual encounter to focus on, again, the connection of substance use to sex, not so much at the person level, like do you use meth, do you use cocaine or crack, but more, did you use this substance prior to or during a sexual encounter, and then assessing that sexual encounter as it happened. Gives us a better idea, we think, of how substance use plays out as it relates to sexual behavior. But when we look at the factors primarily associated with serodiscordant condomless anal intercourse, and this is across different projects, Project Logon and BCS, we found substance use as a factor that was related to serodiscordant CAI. Also partner behaviors, so independent of whether a person, the target, used anything, their partner, if they use something, there was a relationship to condomless anal intercourse for the episode. And then types of partners. And notably, lack of communication about condoms or HIV also being related to serodiscordant condomless anal intercourse, which again is something I'd like to come back to at the end. Hopefully we'll have time. Another area that I've been interested in addition to substance use and mental health, of course, are highly interrelated, but it is looking at the relationship of mental health and risk behavior. And, over 20 years ago, Nicole Krapaz and Gary Marks did well, they've done many different systematic reviews and meta-analyses, but in this meta-analysis, they were interested in negative affect and risk behavior, and showed that when we look at across studies, that there's really a small effect size and limited support for this idea that negative affect or depression is related to risk behavior. But one of the issues with so many of the studies included in the meta-analysis was that there are conceptual, methodological, and design issues that don't allow us to truly understand a temporal relationship or causal relationship between depressed mood or negative affect and risk behavior. And that was a question that really spurred me and sort of spurred my interest in looking at this using a daily diary approach. These approaches have been used a lot more since Krapaz and Marks published this meta-analysis, but still, I don't think we're looking at it across populations, or particularly in the communities, like I said, that are most affected by HIV, nearly as much as we could or potentially should be doing. And so that's essentially, what Kalishman and Weinhardt noted were these conceptual issues. So we wanted to contribute to the literature by addressing some of those conceptual issues. And here, these are findings from our weekly diary, in which we looked at depression and well-being, depression using the CESD, well-being using the FAHI, and wanted to look at both average levels or person level depression and well-being, as well as changes in depression and well-being, changes from a person's average. And what we see is that while we didn't find any relationship between person or person level estimates of depression or well-being, we did see across both our independent variables and our two outcomes, we saw that there was a relationship, such that on days where people experience more depression, we saw a higher probability of UAI and serodiscordant UAI, and on days where they were happier or experienced more well-being, they were less likely to report those episodes. And this is sort of a graphic that sort of shows this relationship. And you can see, again, what we're focused on here is the deviation from a person's average. So it's not just solely looking at fluctuations across the boards. It's really trying to understand, am I feeling better or worse than I normally am? And what are the implications of that for my behaviors? And that's, I think, a really important point, and something that I've been looking at more, in fact, with colleagues at UCLA in the Department of Psychology, is how to model these sort of changes, but thinking about it from a person aspect. Somewhat ironic I'm saying that, since I'm sort of advocating for looking at not just person level variables, but to think about how it's not so much if I'm depressed or if I'm happy, but more if I'm more depressed than usual, if I'm happier than usual, what does that mean? And that's something that we're still, like I said, very interested in looking at, and both the current data and data that is being collected and is planned on being collected. This again looks at the same phenomena, but now on a different data set. This is the BCS data, where we have a sample of all Black and African American younger gay and bisexual men. And you can see, while we do have a between person effect for depression when we use the K10 measure, we have within person effects for both the K10 and the POMS, the profile of mood states, when we look at how, again, changes in depression. So if I'm more depressed than I usually am, I'm more likely to report serodiscordant convalescent anal intercourse. If I'm more depressed, using the POMS, the same finding we see. And this is an outcome we labeled high HIV transmission risk, because unlike in Project Logon, we were able to sort of not just look at, well, did condomless anal intercourse take place, but was there condomless anal intercourse with an HIV unknown or negative status partner for a partner or for a target who was HIV positive, and vice versa. So essentially, this is serodiscordant UAI with a person that was known to be of a different HIV status. And this is just another graphic that helps sort of show what we see when we look at the difference in depression from my normal average. What does that mean in terms of the odds of having a HIV transmission risk episode? Finally, for this, well, I will come back to the BCS data set, but one of the things that we also looked at and the Project Logon study is whether or not we could sort of see the similar kinds of findings when we look at the qualitative accounts of how individuals talked about their experience of having sex. So one of the things we asked in our weekly diary study was if participants had sex, they of course completed a quantitative assessment. We also asked them to tell us, like, how did you feel prior to or during the sexual encounter? And we coded those responses, and then we're able to essentially create quantitative variables out of them. And we see a very similar set of findings, particularly when it comes to anxiety and depression, such that when individuals reported anxiety and depression, they were more likely to also report serodiscordant UAI. Just gonna check. I saw there's a chat. Okay. Maybe I'll wait because I think that might be a question I can answer at the end. So let me just move on. I think I have a good 8 more minutes to the ATN study, which is a daily study of primarily Black and Latinx youth living with HIV. This is a study that really was focused on 2 things: examining the feasibility and acceptability of using different diary approaches to collect both person and sort of daily level variables, and then of course to examine covariation among in this case mental health, substance use, and sex. This was a somewhat complicated study and a big endeavor for my team and for the ATN, in that collecting 60 days of data from this population was something that hadn't been done prior, that we were aware of at least. And folks who've worked with the ATN or who've worked with populations of young HIV positive African American and Latinx young adults know that many of these young adults have really chaotic lives that make it challenging to follow them for 60 days on a daily basis. But thankfully we were able to, again, using some of these approaches that we took. So our sample size was somewhat small, just an N of 67 from 3 different sites. You can see what the eligibility criteria were there. But one of the great things about diary data, and we're still looking at this data even today, is that we get so many observations while we don't have a huge sample size. Ultimately, we had 61 participants complete the full study, but they provided 2,558 days of data, which allows us a great deal of opportunity to look at within person effects. Now, between person, much more difficult. So making comparisons across racial, ethnic groups or age groups, not something that we could do easily in this data set, but certainly looking at what is happening within participants, we can look at pretty effectively here. We use the profile of mood states adolescent. There's an adolescent version of the POMS that's been shown to be reliable. And we captured anxiety, depression, and other mood states using that. We also looked at, we complete or created an assessment using input from a CAB that got at stressful events, social support, and other aspects or other factors that we're interested in. And I'm happy to go over the analyses if people have questions, but we use pretty standardized approaches, mixed methods, in this case linear, but also sometimes logistic, mixed models that allow us to distinguish within and between person differences. So just to show us a little bit of our descriptive findings, looking at substance use, what we found primarily was that our participants used alcohol, cigarettes, and marijuana. We assessed other drugs, but those were the most frequently used. And you can see they were used by, and this is where it's important to understand the distinction between the participant level and the day level. So on the left side of, or the left columns are the participant data, the right columns are the day data. But about a fifth to a third of our participants used the different substances. And you can see the number of times they would use them per day. It's interestingly very similar findings for like the number of days used, about a fifth to a third of the days used for the different substances. And again, you can see the number of times that they take those substances on the days used. We also have our findings on our basically our mood variables, which are just the means and standard deviations. But one of the reasons that I wanted to present some of these descriptive findings is just to highlight the importance of thinking about variation as potentially a person level factor. And again, I know I'm sort of now mixing my terms here, but this is the kind of work that we are trying to do now is look at a little bit in more detail. How can you sort of model, not just sort of see if someone's changing, but what do I look like over time? What do you look like over time when it comes to alcohol use? So if I'm in panel, if you're in panel 1, we'd say it's probably you have sort of a low variation. It's every week or so you're having a drink. Whereas maybe I'm in panel 3, high variation. I'm on and off, on and off. If you look at tobacco use, panel 4, someone who has low variation is someone who probably doesn't use, but had one day of using or uses all the time. Actually, panel 4 would be a person who's smoking cigarettes every day, but there's one day that they don't. The marijuana use is panel 7, the opposite of that. Primarily not using, but one time using, versus say panel 9, where I'm on and off. Some days I use, some days I don't, but it's highly variable over time. What does that mean? What does that suggest for both how it can predict outcomes, or even how it might mediate relationships between person or person level variables or within person factors? That's work that we are looking at now. Oh, I'm sorry. I think someone's not muted. And we can look at the same thing when it comes to mood. We'll go through each of the panels here, but you can see how, again, variation in happiness and calm mood and anxious and depression, these things can all be looked at and do occur with variation. We very seldom see a very static profile. So if just for one really quick example, the depressed group of subjects, panel 10, where you see very little variation. This person is probably not at all depressed. Over our 60 days, they had very little fluctuation in terms of their score. We don't see that quite as often as we see more like an 11 or a 12, where there's a lot of on and off days. And that's particularly with this population. Again, this population of primarily lower SES, HIV infected, young, Black and Latino, gay and bisexual men. We have looked at the relationship between these sort of behaviors of alcohol, nicotine, and marijuana use, and how they relate to happiness, calm, anxious, and depressed mood. And some of these effects that I'm showing you are at the trend or marginal level of significance, but I really want to highlight just again how we can see differences almost even at the at different ends of the sort of side of positive and negative relationships when we look at between versus within persons. So typical level of uses are average or our between person, and daily fluctuations is our within person. And if you just look even at anxious and alcohol use, and this might make sense to folks, but it's still important to highlight, these are marginally significant. I give you that. But what we wanted to highlight here is that whereas typical level of use has a positive relationship to anxiety, daily fluctuations in use has a negative relationship to anxiety. And that would suggest that the more people use, the more anxious they are overall. But on days that people used, they were less anxious. And this is not the only time we see this kind of flipping of an effect. Again, like this is data that we're still looking at, in spite of the fact that it is somewhat old. It still has more treasures that it seems to, well, treasures might not be the best way to put it, but there are more findings that seem to be coming out of it that we value and think are important, particularly when they highlight how these relationships can be so different, almost the antithesis of each other when you look at the between versus the within person level. And while I'm not showing the estimates here, we have it again looking at substance use and sexual risk behavior, where we look at the main drugs that were used by the sample, but focusing here on marijuana and insertive serodiscordant UAI, you can see people that used marijuana overall were less likely to report that behavior, but on days in which they used it, they were more likely. And I see 9 is on, and I'm sure that means I'm out of time. So I'm going to conclude in the next minute. I wanted to go back to this diagram because one of the key things for this work, while I said that I looked at unprotected anal intercourse and condom anal intercourse really without addressing PrEP or U equals U, and that was largely because some of this work was done before that those tools were widely accessible. I think it has relevance because one of the things we do ask about is, did you talk to your partner about HIV or condom use? We ask about this in all of the projects that I've done. And you can see the distribution like that we have some, about a third of the time they do and a third time they don't. But when we looked at what are the variables that shape whether or not people talk about condom use or HIV status, there are several that pop up. But what I wanted to highlight, and this was something that we're in spite again of the age of this data, we're hoping to get out there because I think this finding is important. This is a sample of all young Black gay men. And when they reported having a same race partner compared to having another race partner, they were less likely to discuss condom use and less likely to discuss HIV status compared to when they had a partner of a different race ethnicity status. And I can also say that there was a good deal of variation across the racial ethnic groups in which participants had sex. So we do capture when they had sex with a white person or a Latinx person. And again, we just think that speaks a great deal to the importance of this approach for even understanding things like PrEP and U equals U. Really quickly, I hope that I've made a case for looking at within-person analyses and approaches that can shed light on within-person processes, and that we can hopefully think about even ways of targeting those processes and thinking about interventions for them. I'm happy to talk more about this work. I'm excited by it. So I will definitely answer any questions. But I will just say really quickly, thank you. And sorry to rush through the end. These things always go way quicker than you expect them to. So really appreciate the opportunity to present this.
Thank you so much. And I think you did make a very powerful argument for that. So we want to encourage anyone, if you have questions, either put them in the chat or raise your hand and we can ask you to come off mute. There was one question that came in before asking about the associations with depression and sexual risk behavior, which was, have people also looked at it in the opposite way? Because you could think about ways that depression may actually make people less likely.
They have, yeah, and in fact, yeah, the response that Couchman wrote to the Krepas and Marks piece, they talk about that, but yes, folks have particularly talked about that, and this is why I mentioned at the start that I was really focusing on non-clinical populations, like folks that don't have clinical depression or are like with substance use disorder per se, because we definitely see if you're clinically depressed, you're less likely to have sex. So I'm sort of excluding that population, but there certainly is that relationship. Yeah.
And then I had a related question, because in some of your data where you were talking about depression, you were using the PALMS and the Kessler 10 score, which is like a score of distress. And so I'm actually wondering, are these associations really driven by the depression, or could it be by some of the other things that those scores also measure, including anxiety?
I think, no, it's a really good point. And part of the reason that we use these different measures was to provide some sort of validation to these findings. Like, so if we look at it from different perspectives, we still see the same. But I agree that a lot of these tools are measuring more than depressed affect or mood. A lot of times it's stress and stressful situations. I had a slide that I removed, but that sort of showed all the different stressors that our ATN participants reported experiencing from a daily basis, because I wanted to make this case of, see all these stressors that they're experiencing, that is going to tug and push and pull on mood. And I think of those things as highly interrelated. So I think, yeah, we might be getting at more than, or something, not just depressed mood when we're looking at these particular measures.
Are there other questions or comments people have? I think give us a lot of food for thought.
Was there a correlation with repeated episodes with the same person? Okay, was there any correlation between repeated episodes with the same partner or increased or decreased conversation around HIV? Now, this is a really great question. I will say this sample, we wanted folks that were not currently in a relationship and that reported having more than one partner. But so I know that these are folks that had multiple partners, but we did not look to see if the repeated episodes would have increased or decreased conversations. I think that's a really important point to get at, that sort of nuance, that level of nuance. Unfortunately, we weren't able to in this particular study, but that is something that I'm definitely thoughtful of. So I appreciate that question and observation.
Question. You're finding about the same race partner and less discussion is pretty provocative. Was that for both HIV and condom use? And what is your thought? Like, is there anything from the qualitative data that might explain that?
Yeah, so we haven't looked at the qualitative data we collected for this project, but that's actually a really good idea. I do have thoughts about it. I think stigma plays a big role. I think this is where we still need interventions that aren't biomedical that can reduce the stigma that I think is not unique to Black gay men, but is very prevalent in the community that exists, particularly lower SES Black men who are not necessarily easily able to access some of the tools that we have. But when I looked at, when we wrote up these findings, and all of the work that we could find on sexual health communication among Black gay men was qualitative. And there's not much quantitative out there. And the qualitative work definitely highlights the role of stigma and sort of shaping why men will or will not talk about HIV or condom use with one another.
Great point. So so Johnny's saying thank you to their speaker for excellent presentation, and he also put in the chat a evaluation form. So we do really appreciate if people will take just a few minutes to complete that. Probably will take you less than a minute to do so, but and Dr. Wilson gave his information, so I'm sure you can follow up with him if you have other questions. Getting kudos coming in on the messages, but thank you so much for being here. Dami, was there anything else?
No, thank you for the presentation, and we'll send an email out with the evaluation as well and the recording once it's available. Thank you once again, Dr. Harawa. Thank you, Dr. Wilson, and have a great day, everyone.
Thank you all. It's good to see some names that are familiar. Take care.